Hello everyone. Thank you so much for joining us today for Survivorship Care Plans, implementing the ASCO template. My name is Shira Morales and I'm the Project Manager for Healthcare Professional Education at the GW Cancer Institute. Now before we get started, I just want to take a few minutes and go over a few housekeeping remarks. We ask that everyone keep their phones on mute to avoid any background noise and disruption during the program. And also please be aware that today's program is being recorded. During this webinar, we will use the Q&A feature. You will see the Q&A box at the bottom right hand of your screen. If at any time during the presentation you have a question, please type it in and we will address it during the Q&A portion at the end of the webinar. The questions are anonymous and I will repeat the question. So we will take questions at the end of the presentation, but feel free to write the questions in the Q&A box as we go along and we will make sure to answer them during the time allotted. We will also use the chat box feature, which is on the top right side of your screen. You can use the chat box to interact with each other. Because we will probably be talking during the presentation, we won't be able to keep up with the chat. So if you want to ask a question, just make sure you use the Q&A box on the bottom right. And as a note, before we get started, the PDF of the slides will be available for download during the Q&A section of the webinar. We will also send out the PDF slides and a link to the archived webinar to all of the webinar participants. The recording will be archived on our website along with all of our previous webinars. For all of you active social media lights, you can live tweet us throughout the webinar at GWCancerINST and use the hashtag #CASNPwebinar. So I want to take a moment to review today's agenda. I will provide a brief overview of the Center for the Advancement of Cancer Survivorship, Navigation, and Policy. We will display a brief poll for all the participants to complete. Dr. Deborah Mayer will provide a presentation on survivorship care plans implementing the ASCO template. And we will conclude the webinar with a participant Q&A, and we will do so again through that Q&A feature on the bottom right hand of your screen. So I want to provide a brief overview of the Center for the Advancement of Cancer Survivorship, Navigation, and Policy, which brings you today's webinar. The Center for the Advancement of Cancer Survivorship, Navigation, and Policy, which we affectionately call CA-SNAP, was created in 2009 through a generous grant from Pfizer Global Health Partnerships Program. The mission of the center is to advance cancer survivorship and patient navigation efforts locally and nationally through education and training, policy analysis, outreach, and research. The center offers survivorship and navigation resources that are available online at our website and through a monthly e-newsletter. Additional material is sent through our CA-SNAP mailing list to over 2,400 subscribers. We write white papers, create case studies, and work cooperatively with other healthcare organizations to advance patient-centered care. We also share summaries of meetings and roundtables we have hosted to catalyze patient navigation, cancer survivorship, and patient-centered care initiatives. Through CA-SNAP, we have offered several trainings. In 2013, we were awarded funding from the Centers for Disease Control and Prevention that will help us translate our existing in-person trainings to an online format to make them available at no charge for participants. We recently launched our executive training on navigation and survivorship, which is the nuts and bolts training for building and sustaining navigation and survivorship programs. We are also working diligently to launch our second online training, Oncology Patient Navigation, The Fundamentals, which should be available in the spring. If there are any topics that you would like to know more about, please just let us know. Our email is listed on the screen as casnp@gwu.edu. Today's presenter is very much admired here at the GW Cancer Institute, and we are very excited to have her. Dr. Deborah K. Mayer is an advanced practice oncology nurse who has consulted with organizations on issues to improve cancer care and has over 30 years of cancer nursing practice, education, research, and management experience. Dr. Mayer earned her PhD from the University of Utah, her MSN from Yale University, her BSN from Excelsior College, her nurse practitioner certificate from the University of Maryland, and her diploma from Pennsylvania Hospital School of Nursing. Her program of research focuses on the issues facing cancer survivors and improving cancer care. We welcome you, Dr. Mayer.
Thank you very much, and I welcome everybody who's participating, and I see a lot of names that I recognize, my colleagues and others who are doing work in this area, and hope that you'll be sharing your experiences as well. As many of you know, this is something that's been going on for a long time, so I want to really get a sense from the audience about a couple of issues. So there's a polling feature, and we want to know, first of all, are you currently implementing survivorship care plans if you're in a clinical practice? Great. And then the second question is whether you have an electronic health record in your practice. And then the third question that I'm asking is about if you have an electronic health record, are you actually implementing the survivorship care plan within the electronic health record? Okay, so I think this is going to be very interesting as we discuss some of the issues of implementation, which is what I really hope we will be able to spend some time on it. So thank you for voting, and it's given us a real snapshot of where people are clinically. And if we go back, great. So we'll use that as background, where a lot of people are trying to implement survivorship care plans, but fewer are actually doing it within their electronic health record. So we're going to do a little bit of history, and a lot of people that are on the call have been part of this, of the evolution of the survivorship care plans, and then talk about components of the survivorship care plan, reviewing the Commission on Cancer standard and the changes and evolution of that, and then talk about the ASCO template in that process, and then really want to talk about developing a process for implementing survivorship care plans, and then identify components of quality cancer survivorship care, because as you'll see, filling out the care plan is only one part of the care, and we'll talk about each of these aspects. So as many of you remember, the President's Cancer Panel early in 2000s addressed issues of survivors, but it was the Institute of Medicine's Lost in Transition publication that was done in 2005 that really brought attention to many of the needs of people ending treatment and going on and trying to resume their life in some way that was affected by cancer. It was at that time that the recommendation was made in the report that patients completing primary treatment should be provided with a comprehensive care summary and follow-up plan that's clearly and effectively explained, and that the survivorship care plan should be written by the principal providers who coordinated oncology treatment, and that this service should be reimbursed by third-party payers. So that was the goal. It's now 10 years later, and we may be starting to meet some of those goals. The essential components of care that were to be included in a survivorship care plan, but were also to extend beyond that, included the prevention of recurrent or new cancers or other late effects of treatment, the surveillance of cancer spread, recurrence, or new cancers, and of the medical and psychosocial late effects, and the intervention for consequences of the cancer and its treatment, no matter what they were. And the evidence behind interventions is lagging, as is our knowledge of late effects, but we'll talk about all of that as we go. And then the last piece is about coordination of care between the specialist and primary care providers to ensure that all the survivors' health needs are met. This is just another way to depict that, but it is a dynamic relationship not only between the survivor and their oncologist and their primary care provider, but it's really meant to be a relationship between the oncologists and the primary care providers as well. It's meant to enhance communication, to coordinate care, and making sure there's not under or over surveillance, and to identify and manage long-term and late effects, as well as what patients want in health monitoring and health promotion. So when you think about the care plan development and delivery, you must keep this triad in mind and the purposes of what it's meant to do. Now in 2011, the first Commission on Cancer Standard 3.3 is listed here, where it's the role of the Cancer Care Committee to develop and implement a process to implement survivorship care plans, and the goal was that all patients by 2015 were going to be getting survivorship care plans. I think that what's happened is we've made enough work visible about what it takes to achieve this that they have since revised their standard requirements, and we will go through that in a few minutes. But generally, even though there hasn't been strong evidence supporting the impact of a survivorship care plan, there's generally positive endorsement of that from survivors themselves, primary care providers, and oncology providers, as far as it makes good clinical sense. There have been a number of studies that have been done. There have been 3 large randomized controlled trials that have been reported. There's been many other types of studies that have been reported. They haven't been ringingly endorsing the impact, but there's a lot of methodologic issues that still need to be addressed in conducting survivorship care plan research, in thinking about proximal outcomes and how do we measure them, etc. But there's starting to be some preliminary data. One was the SPARK study, which is a national NCI-sponsored study of oncologists and primary care providers about their roles and responsibilities, that in a recent publication, primary care providers who received a survivorship cancer care plan were 9 times more likely to work with the patient on survivorship issues than if they hadn't received it. And we have a small abstract of a pilot study that's going in that also shows both patients and primary care providers show more confidence in the survivorship plan and knowing what's going to happen. That needs to be validated in a larger study. But what we do know is that even with that being good sense and some preliminary data starting to come in, there's been a number of barriers, and that has also been documented in the literature. All the things I'm talking about are references that you'll see at the end of the slides that are included. But one is that we saw nationally that some of the people developed them for some of the patients, some of the time, in some of the practices. And to do this in a more consistent way is going to take a lot of time to figure out sort of the systems issues to do this. Another barrier was how long it took to complete the templates that were available, and that was unreimbursed time. Now, I will tell you that that may be changing because CMS is currently, as of January 1st, going to be, they've adopted a new CPT code, 99490, which is a chronic care management service of 20 minutes of clinical staff time directed by a physician or other health-qualified healthcare professional per calendar month. So it would reimburse the actual development of the survivorship care plan, where you can get reimbursed currently for the visit, but not for the time it took to complete the care plan. So we can talk more about that. The other is the lack of clarity regarding who completes it and then who maintains it. So when you're talking about oncologists, it may be just the surgeon, but it may be the surgeon, medical oncologist, and radiation oncologist. So it's defining who's the last person to touch the patient, or how you can coordinate those efforts, who's going to do those, and every practice is different into what that's going to mean. And I will come back and talk a little bit more about the new CPT billing codes again. The lack of partnership between oncology and primary care providers has been very difficult, and you see that in the results of the SPARK studies around communication and who assumes responsibility for different aspects of care, and then the paucity of data so far about the change in outcomes when survivorship care plans are used. Again, I think that's going to change over time. And then the real big challenge, which we'll be talking more about today, is using existing templates within an electronic health record, because it's very difficult to do, but it has been done, and we'll talk about some examples of that. So as a result of that, ASCO took the leadership through their survivorship committee to say that it was important to look at that. They have a quality cancer survivorship care paper that's by Mary McCabe and others that's referenced at the end. But also we had a clinical expert statement that discussed the importance that survivorship care plans should be delivered to both the patient and primary care provider, that it summarized the minimum amount of data that's needed. In the old templates, it was all things to all people and included a lot of information for a lot of different people, not always in an easy way for the patient or primary care provider to understand or know the importance of. So we really tried to look at what was really necessary for those two end users, and then identifies and provides some solutions of barriers to implementation. And that was what's in the ASCO paper about this whole project we're going to be talking about. And I do want to acknowledge my co-authors and co-contributors to this project, which took about 2 years to unfold from time of initiation to publication, and we're still working on some aspects of it. So what we did is we actually did a literature review, and then we had a stakeholders conference, which included patients, primary care providers, insurers, all aspects of oncology care providers, et cetera. And what we asked them to do based on the survey results is really identify what was the minimum set of data that needed to be in these to be useful to the survivor and primary care provider. That's setting aside that someday they may be useful for research or other kinds of things, but really focusing on the end users. We did this conference, and we had breakout groups, and we made sure that every stakeholder was represented in each of the groups. So it wasn't nurses talking to nurses. It was nurses as part of the group, or survivors in the group, and different oncologists in the group, et cetera. And then they came back and reported what they came up with. And basically, we kept the discussion going until there was general consensus about what we thought should be included in this. And so what we really wanted to be clear about is when people talk about a survivorship care plan, we're really talking about a tool that has two components of information. One is a treatment summary about what happened to the patient, and the other is the care plan, which is intended to facilitate communication and coordination of care between the three parties, the patient, oncology provider, and primary care providers. What we were also very clear about is handing the patient a piece of paper is not what the intent of this process is. You may meet the letter of the law for Commission on Cancer's review, but it's not really meaning the intent, because this tool is meant to be an adjunct to the discussions when this is reviewed with the patient and then delivered to the primary care provider for understanding. And it should be simple, clear, and understandable as possible for the variety of end users. And as I'd like to say, it shouldn't be an onco-speak, because it's only something we understand and not necessarily the rest of the world. And it's not intended to be nor replace the medical record. And so when people were trying to stuff all this detail in it, it was almost as if it was meant to replace the medical record, but that wasn't really very useful for the patient or the primary care provider, because there was a lot of things that didn't make sense to them in this. So we really want to make sure that the intended use is for those two users, and that it's in a way that they can understand it. Another assumptions were that it's intended for people with curative intent for adult cancers, regardless of type of cancer, but that there's a number of other groups of survivors that we're not addressing in this. And so over time, you may see needs of patients living with advanced disease wanting something similar but not identical to this. And so it's really intended for people who are thought to be cured with their treatment, and then how to live with all the effects of that. And it's intended to be presented to people at the end of treatment who have no evidence of disease, but many people will make a decision that that's at the end of acute care, and if they're on hormonal therapy or ongoing maintenance therapy, that can be delivered before 10 years of hormonal therapy for breast cancer. It really should be thought of as being done at the end of acute care. And that it's an evolving document that can be updated and reissued, but depending on how you implement it, you may want to just develop new ones, or you may want to keep it open. There's different ways of managing that within an electronic health record. So just as a reminder, what's in the treatment summary includes contact information for the providers and where the patient received their treatment, so that if you ever had to go back to get those records, you would know who did that. Basic diagnostic and staging information, information on surgery, radiation therapy, and systemic therapies, whether chemotherapy or targeted therapies or whatever. And then if the patient has ongoing therapy-related toxicities at the end of treatment when this is being developed. So for example, if the patient had neutropenia and recovered and isn't on an ongoing therapy that's continuing it, that's less relevant to the primary care provider when treatment's over than the fact that they may have grade 2 peripheral neuropathies. And so what the primary care providers want to know is what is still an issue. Is it fatigue? Is it peripheral neuropathies or whatever? So that they can understand what the baseline post-treatment looks like. In the follow-up care plan, it's meant to aid what's going to happen next, and that's in two ways. One is in the surveillance plan to detect recurrence or late side effects, interventions to manage ongoing problems and its treatment and the detection of them, and then the general age and gender-appropriate health care, including cancer screening, and then general health promotion. And one of the reasons that detailing the surveillance is important is it should be very clear not only what is due and when, but who's going to do that. So if the patient lives far away and they need a CEA every 3 months, the primary care provider certainly can do that and make sure it gets back to the oncology center, or should be notified about when to notify them for any increases. Likewise, if the patient's going to have a mammogram or colonoscopy, it should be clear when that's being done and who's going to order it, so we're not under or over testing people. Now, this is just part of the data that's in the ASCO paper, but basically prior to launching, it was pilot tested in 11 practice sites and 45 care plans were completed. And as you can see here, the range is from strongly disagree to strongly agree. The higher numbers is a better response. And that most people thought it was at least relatively easy to complete. Now, this was paper and pencil. It was not integrated, and it was the first time these people saw this form. It wasn't something they were familiar with. That it was clear what was needed, that it included what was needed, and that it was useful in discussing care. And that the average time to complete was 30 minutes, but the range was 10 to 75, depending on the complexity of the patient. And so the integration of this into an electronic health record, where some of this may be auto-completed, may work to decrease the amount of time that it will take to complete these. Now, coming back to the Commission on Cancer, this is the new requirements, because what they did is they backed off the 100% by January 2015, which would be late on anyway, but is to titrate it up starting at 10% this year. So you would want to find out from your tumor registry how many new cases you have, and of those, what percentage of them look like they're non-metastatic patients. And then you would want 10% of that number is what your target's going to be by the end of 2015. Likewise, that would be 25%, going all the way up to shooting for 100% in the next 5 years, although we know nobody ever gets 100% at anything, but at least moving in the direction that all eligible patients would receive them. And that what they were recommending is that you focus on a couple of diseases to start this process and then go from there. And I can share with you at UNC what we're doing is, of the 12 tumor groups that we're doing in an academic medical center, we're leading with one cancer in the GU group because they volunteered, and then we're going to expand it to the other GU cancers. We're doing bladder cancer first, and then we're going to cover the others and get the GU group up and running as an early adopter. And then the GYN group volunteered to be next, so we're going to work with them. And then basically, as this goes on, more people will pick this up from the early adopters until you get the last group that will probably do this kicking and screaming, but we'll save them to the last. So this is what they're looking at. As what this means, though, is you have to have an ability to identify who these patients are. And one of the challenges is identifying who's eligible to get one of these, when their treatment's ending, who's going to see them, and when should this be developed. So we're going to talk about some of those details, because it's not just about filling out the form. So as I'm mentioning here in the challenges is, how do you track patients, and will you do that electronically? Will you do that through your tumor board or your tumor registry? The reimbursement issue may get resolved if the CPT code works for the chronic management services. And then making sure that we're adapting the templates that we have to reach the populations we're working with. So if you work with a primarily immigrant population where English is a second language, even what we've created may be too high level, or you may need to change it for different disease groups for what their needs are. And so the other thing you might want to think about is how you're going to evaluate if these have been delivered and whether people find them effective or satisfied with their use. Now, there's a lot of different templates available, and there's a lot of different resources about doing this, and many institutions have created their own based on these principles. And I'm just listing a few of these here. There's also a number of e-health companies that are coming up with solutions that might integrate with existing electronic health records. So this is definitely a very large growing area, but it's no small feat once you decided what you're going to do to try and implement to make that happen. So here are the questions that I would recommend if you're thinking of implementing this in your institution, having a group of people work with you to try and figure this out, because this is where the devil's in the details. As I mentioned, you need to figure out who's eligible to receive one. And if you have a lot of referrals with patients with advanced disease, those aren't the patients that are going to be needing these. So how do you identify those? And then how do you track them to know when they're ending treatment and get the survivorship care plan delivered, but also whether it was delivered? So you need to be able to figure out how you will do all of that. Again, you can bill for the visit when it's delivered for whatever is the appropriate evaluation and management service, depending on who's doing the delivering. Many places, the advanced practice providers, nurse practitioners or physician assistants are doing it. In some places, nurse navigators are doing it. In other places, the physicians are doing it. And then the other is the actual tracking, so we'll be able to determine your denominator, from how many you're actually developing and delivering. So you need to think about how you're going to track this so that when you have to create your reports for the Commission on Cancer, you'll be able to do this. And then the question is, how can this become integrated so it becomes a sustained standard of care? And that remains to be seen. I'm hoping by making this easy and integrating that, and people will learn that this is just part of what you do, as we've integrated many other things into our practices. And then the question is whether you're going to do any follow-up evaluation with your populations around satisfaction of care or measuring utilization of services, etc. So in the paper that I referenced at the end, when we talk about what is high-quality cancer survivorship care, the survivorship care plan falls under the recommendations about that. So when you read that paper in detail, it talks about all these different aspects of models of care, guidance, education for survivors as well as providers, and then research and advocacy and policy issues that need to be addressed. These are the key recommendations in the paper. I'm not going to go through all of these, but each of these bulleted items have many paragraphs in the paper that actually discuss and describe what they mean by each of these guidelines. So this is the clinical guidance one, trying to standardize the long-term follow-up of adult survivors, developing evidence-based practice guidelines, etc. And so this is what goes beyond the issues of a survivorship care plan. So when you're talking about how you're going to develop and implement the care plan, these questions need to be addressed as well, because you need to know what your support services are, who's going to be following these patients, when do they get referred for higher level services, who's more at risk for things that you need to be monitoring for. And that comes back to the models of survivorship. There are currently not strong evidence that there's any one model that's better than another. There's many models that are out there, and again, there's a number of papers that discuss the different models, whether they're strictly oncology, strictly primary care, or a shared care model, or survivorship specialty models. And again, it depends on how big your practices are, what your resources are as far as providers are, et cetera, as to what makes the most sense. But again, you may want to do some pilot testing of different models until you find the one that works best for in the system that you're working at. And then this is where the survivorship care plan actually gets mentioned in the assuring high quality of care, which is promoting strategies to ensure that every survivor receives a written, coordinated treatment summary and follow-up care plan, aka a survivorship care plan, that providers are reimbursed for this service by third-party payers. So again, I'm going to tell you, you can, when they're delivered, you would bill for an E&M code relative to that visit. Now, when I deliver them, I do a surveillance exam on a patient to see if they've had any recurrence and evaluate them for effects of treatment. So I actually bill for the level of exam I do and then the amount of counseling I do around the survivorship care plan delivery and review. So I bill for an E&M code appropriate to that. Now, as I mentioned, the CMS code, and I'll give you that number again, is 99490. It's CPT code 99490 is just out, and it's called the Chronic Care Management Services. And so you can Google that, and there's been a few small articles more in internal medicine about how to use this for diabetes and other diseases, but it actually looks like it would be everything in the survivorship care plan meets the requirements that are spelled out in that CPT code. So what you would do is you would have an E&M code and a CPT code for that visit, and that would then bill for and allow you to get reimbursed for the development of the care plan as well as the delivery of it. And that's huge. That's new. That should reduce some barriers of people saying this is another unfunded mandate. Now you will be able to get reimbursed for that. And E&M codes are evaluation and management codes that when a clinician sees a patient, that's how billing is established based on the level, and there's 5 levels, 1 through 5, and each one requires a certain amount of evaluation and management that goes on with that visit. So if you're a practitioner, it's drilled into you what those numbers mean and what you have to do for each of those visits, but it also is a reflection of how much you get reimbursed for by your insurer. Provider education, that's an ongoing issue, and one of the things that I've noticed is how little the milestones for the oncology training programs, they now have some survivorship care components in their milestones for their training programs, but, and I'm looking at family medicine and internal medicine as well to see where this is built into their training program. I know with oncology nurse practitioners, it's built into our blueprint for content for certification. But we need to think about how providers are going to get educated, not just about filling out the form, but what real survivorship care looks like. And then we have to think about education for survivors and their families. So for example, many institutions offer chemotherapy classes if somebody's going to start chemotherapy. I think we should start thinking about developing end-of-treatment classes that help patients transition to know what's going to happen next, including asking for a survivorship care plan. And it's something I've been toying around with. I haven't done it yet, but I want to play with it. But the idea of maybe having weekly or monthly classes that people who end treatment can come in no matter what the treatment is, to hear about the emotional transitions that it takes to end treatment, as well as what the physical recovery patterns may look like, as well as the expectations about receiving a survivorship care plan. I think there's a lot more we can do in education, and both NCI and ASCO have some wonderful booklets around survivorship or what happens after treatment ends that are really worthwhile to augment the actual survivorship care plan. And then, of course, there's always the need for more research, and especially in issues of development and implementation and evaluation of outcomes of not only the survivorship care plan, but of long-term effects and late effects of survivors. We only have some longitudinal data of adult survivors that don't even mirror what we have for childhood cancer survivors. And so we may not understand what happens 20, 30, and 40 years out because they're seen by primary care, and we're just starting to get a larger group of long-term survivors to really appreciate what some of those issues are. And most of those people will not be followed in oncology. They'll be seen there by their primary care provider. So, for example, how is a primary care provider going to know that the early onset of heart disease may have been related to earlier cancer treatments? And so there's not a really good way to capture all of that yet, but it's ripe for some good research opportunities. And then, of course, there's policy and advocacy issues such as the CPT code and getting reimbursed for these services. It's not just something you say we need it and it happens. It takes a lot of work to make those things come through. So I'm going to summarize because I can see just from the things that are getting posted, I think there's going to be a lot of questions and discussion about what's going on. But the bottom line is that treatment summaries and care plans or some survivorship care plans are tools believed to help improve the care and health of cancer survivors. We need to show that over time. But it's a piece of paper. And unless the full intent of this is used when developing and delivering the piece of paper, I don't think we can expect powerful outcomes to come from it. But I do know when I deliver them myself clinically that patients, it's like patients taking a deep breath and reviewing what they've been through, asking questions that may not have been clear to them before. For example, I follow women with breast cancer in a survivorship clinic, and a lot of times they obviously know they have breast cancer, but they may want to review their pathology report or really understand what it means to be estrogen receptor positive or triple negative. It's also when they may start having other questions like, what does this mean for my family? Should we consider genetic testing? That in the early hubbub of being diagnosed and treated gets sort of pushed down in the priority list, that these things start surfacing at this transition time. So that can be very, very helpful. And it's also helpful to normalize for patients that this is a real transition time, that during treatment, your head's down and you're showing up for your next appointment and you're trying to get through what's being recommended. When treatment ends like this, it's often a time when emotionally it hits the patient what they've been through. And it's a very good time to normalize that this is a transition period that may be full of anxiety or depression or angst about what's next, and that that's very normal and that that takes time to overcome. We know that developing survivorship care plans can be time and resource intensive, but I think there's a lot of smart people out there working on these things to make them less time and resource intensive. And I think as they get integrated into electronic health records, and I'm sure many of you are Epic users as we are, that it's both helpful and not helpful depending on how that goes. But we have it so that we've created drop-down lists and that there's auto-complete features. My goal is to get the survivorship care plan down so that it takes about 5 minutes to finish and that it's auto-completed ahead of time so that all you're doing is really a quality improvement review and then adding anything that needs to be tailored specifically to that patient during the visit. And there are multiple templates, and depending on your practice and your population, you may decide what you want to use. It's not so much the template form as it is the elements that are in it and how you deliver it. And also to remember that one size does not fit all. I mean, by the patient populations, by where your practice is, by what your practice is about, you may need to adapt all of this to work for you. I think what's going to matter is that the right people are sitting around the table discussing all of this. And the other is survivorship care plans should not stand alone but be used as a communication tool as part of the whole survivorship care that's being delivered. And so if it's really focusing about filling out the form and getting it delivered, it's sort of missing the major point of what this is supposed to be about. So you have to work out some of the details about how that's going to happen, but it shouldn't be in isolation for how are we going to keep primary care providers involved, how are we going to make sure patients know when and where and how they're supposed to get their follow-up. So there's the details of how to do this, but it's got to be in the context of the bigger picture of what's going on. Now, ASCO has promoted a whole compendium of information, and there's a number of other organizations that have this information. This is just one link, but there's a lot of tools and papers and what have you. And that it will be updated over time. For example, there's going to be new survivorship care plans eventually released following the ASCO template for breast cancer, colorectal, lung, and some non-Hodgkin's lymphoma patients, but they're not up yet, but they will be before the year's out. But the generic template is currently posted as a Word document that you can take and use and adapt and implement in any way. So there's some specific references that I've used that are all listed here, but it's a lot of content in the last 40 minutes, and I have a feeling that there's going to be lots of questions and comments about how people use it and any other questions that you may have. So I think at this point I would like to open it up for questions. The other is that there are links to the compendium. There's a link to the evaluation for the program, and also at the bottom there are some files you can download. We have an editorial I wrote about survivorship care plans for the Clinical Journal of Oncology Nursing that reviews a lot of this information, and we've included that editorial as a download here for you to use as well.
Thank you so much, Dr. Mayer. As we were kind of trying to follow along here with the chat, we definitely noticed some confusion about the billing code and their use. So if you could maybe just readdress that and explain. I know you gave two codes, the CPT code and the E&M code, and maybe differentiate between the two.
Okay. So an E&M code is what you get whenever you go to see your doctor or nurse practitioner or what have you. It's called an evaluation and management code. And it's based on what level of service you're getting. If you're just coming in for a sore throat, that's one level. If you've been newly diagnosed with cancer or being seen for the first time, that's another level. And those numbers are 1 to 5, and the provider assigns that on their checkout slip or however they code it in their electronic health records. That's been in existence forever. And when somebody delivers a survivorship care plan, if they're a provider that can get reimbursed, would just use whatever appropriate code for that visit would be. So if you just reviewed the code, it might be an education and counseling session versus if you did the whole surveillance visit, it would be another level. The other code, which is brand new, is the CPT code, which is a procedural code, and CMS has just adopted it as of January 1st. Now, for example, I'm trying to get our electronic health records to implement the code so that when I do a care plan, I can code for it and it will pull this code up, and then it will be part of the billing that occurs. So just because it exists doesn't mean that it's actually available in your billing system yet. So you'll have to work with your billing people or ask them about it. But the new code number, as I've mentioned, is 99490, and it's a chronic care management services code where it's about writing up a care coordination document. And so you can Google that. You can Google the code. There's a couple of articles about it, but it's actually not meant for survivorship care plans. It's meant for chronic care management and the time and effort that's spent in calling or talking to or writing to other providers about people with chronic illnesses. But what the elements the CMS is requiring to be reimbursed for that CPT code, all of that is what's already in a survivorship care plan. So we're going to try using that CPT code as soon as I can get Epic to put the number in and see about whether we can start getting reimbursed for that. I hope that answers the question, but if not, please let us know.
Okay, thank you so much for clarification. We're going to go through, and the next question states, you mentioned that you all are starting with one disease site and phasing in others. Are you approaching the 10% when you're only focusing on one disease site, and will you be able to reach 10% with one disease site?
No, unless you are a really huge, huge service, but that's still not going to meet the 10% of the institution. If you're familiar with Everett Rogers' diffusion of innovation, you know that it takes a while before people catch on to do this routinely. And so what we wanted to work with is early adopters, the people who were the first to buy your DVD players or the first to get an iPhone or whatever. Those early adopters are the ones who are going to have the ability to tolerate all the tweaking that's going to need to go on to make this work. And so when we did this, we have 12 tumor groups in an academic medical center, and we sent out a survey and asked who would like to be the guinea pigs for all this, and the GU group stepped forward. And so we've been working out all the details, and it's simple in concept, but it's, for example, we integrated the template into our electronic health record, but not all the buttons worked, or when you hit send, it didn't necessarily go to the primary care provider, or the autocomplete wasn't complete because people weren't filling out the diagnosis and staging information within Epic, so then it didn't autocomplete in the care plan. So you don't want to roll this out on day one to everybody, because you're going to have a lot of things like that to work out, and there's going to be a lot of things you didn't think about that you're going to have to address. So we're using the GU group because they're good sports and they were willing to be guinea pigs to figure that out. And then we're going to start unveiling it for the other tumor groups and trying to give them some control to adapt it based on their patient populations. But the things that aren't up for discussion is that they're going to do it, and that what we're telling them they should be doing it is in the first real follow-up visit after treatment ends. I don't mean the 1 week post-op surgical visit, but the one that's 6 weeks out or 12 weeks out should be delivered as soon as treatment's over, because in our focus groups and discussions with patients, they want it sooner than later. And I have personally delivered it to people who are 6, 7 years out, but that it's nice for their records, but it doesn't have the same impact as somebody who's just ending treatment saying, what's next?
Okay, thank you so much. We have a few questions, so I'm just trying to get through them. Next question is, what is something that a cancer coalition could do to help develop survivorship care plans? Is it more about education?
Good question. And I'm sure other people will have other ideas about this. One is, it will be helpful to have, instead of the generic template, maybe more specific templates by cancer groups that adopt evidence-based surveillance, or, pre-populate them as much as possible, so that what you really then do is just fill in the patient-related information. And that's one of the things that the ASCO templates for the specific diseases is trying to do, but there's a lot of them to do that for. The patient education, what I tell my patients is, if you don't get one of these, you should ask for them. Because I don't know if you remember, or if any of you are old enough to remember, Pap smears were available before they were routinely done for women. Now we're starting back off again, but that's a different story. But it was when the Pap smear story got into Good Housekeeping and Women's Day, and women started coming in and saying, I want one of these tests, that it started becoming incorporated into daily GYN care and women's health. That's what I want to happen with survivorship care plans. As our systems are struggling to make this happen, the more patients ask for them, the more they realize how important that is. So when I talk to public or patient population groups and talks and what have you, I ask how many of them have received anything like this, and I've never yet had anybody raise their hand. And then I tell them, at your next visit, go in and ask for one. I'm sure I'm not going to be very popular with some people, but it's one way to build some momentum around this.
Okay. So I have someone asking if you could share a website or a reputable place to research more about the CPT code, the uses for it, and the restrictions.
There was an article at the American College of Physicians internist site, so I can give you the title of it and you can Google it. It's called ACP Internist, and the article is from January of 2015, and it's called Chronic Care Management at Last and How to Code for It. And that goes through all these details.
Okay.
And that's really meant for internal medicine or family physicians, but it does, and they also have a chronic care management toolkit, what practices need to do to implement and bill CCM codes. And that's all at the American College of Physicians website.
Okay, we will look for that, and we will try our best to have those links up for the participants, hopefully in the next few minutes. Okay,
Great.
wonderful. The next question states, oops, sorry. Okay, can you describe the communication process with PCPs so that there is neither under or over surveillance for follow-up?
In the template, I'm sorry.
That's twofold. And then can you share what has worked and what hasn't worked?
Well, we're still measuring that, and I think what we're going to have to do is do studies to look at the downstream effect of the surveillance over or underuse. But first you have to get these care plans out and adopted to be able to ask those questions. So if nobody's been using them, it's hard to tell. So in the template, we have a table that says, there's two tables, and you don't have to have it as a table, but it looks fine that way. Is one table is about what providers you should see and how often you should see them. And one thing I would like to note is if you are getting 3 treatments and the patient's going to be seeing the surgeon, the radiation oncologist, and the medical oncologist, it's really important that people rotate their visits. Because I have patients who come in and they've seen somebody 2 weeks before, and then they're not going to see anybody again, and they don't need those clustered visits. And so in your own institution, it would be really helpful if you could coordinate care even amongst the oncology team to say if the patient needs to be seen every 3 months, we can make that happen, but we'll take turns. So maybe the patient only sees their radiation oncologist once a year and their surgeon once a year. And so that's the rotation for clinical visits. The next table has the same concept for testing and what should be done and when it should be done, but the provider responsible for that testing, for coordinating that test. So for example, if it's a breast cancer patient, we'll take care of the mammogram, but the primary care provider should probably take care of the colonoscopy. And that's where that table can be used. And we have a statement in there to the primary care providers that they should be responsible for non-cancer related care, including cancer screening not relevant to their primary cancer. And so that we're clear who's doing what. And it doesn't matter if your program wants to do all the cancer screening, that's great, but then make sure the primary care provider knows you're doing it and they don't need to.
Okay, wonderful, thank you. And I think you touched upon this, but again, they're just asking for clarification as far as what providers can bill for delivering the care plan?
Well, anybody who can bill for a visit now. I mean, so if it's a physician, a nurse practitioner, a physician assistant, and I don't know if nurse navigators or educators can bill for those services. They probably can if it's incident to another visit. So that's something that somebody should talk to the billing people in their own institution about how that would work.
Okay, thank you. And another question is, my understanding of 10% of our selected disease sites, not 10% of the total cases for 2015, and they're wondering whether they're incorrect on the COC expectation for 2015.
I didn't see anything for disease group that way. I saw it as total.
Okay.
But that's how I'm interpreting it. It doesn't say anything about 10% by disease group. So again, that goes back to your tumor registry. Like we get over between 5,000 and 6,000 new cases a year. If they were all non-metastatic disease, that would mean 500 to 600 care plans. If half of our patients are advanced disease, that would mean 250 care plans. Now, how you do that, what they're saying is you may want to start with your bigger solid tumor groups. However you do that number is however, it may make more sense because breast is big. You do your breast group plus some others. We're saving our leukemia and lymphomas to the end because we're not sure that this is as relevant or figure out how we're going to tailor it for patients who have bone marrow transplants, who may be no evidence of disease at the end. So we're saving some of the tougher ones to the end once we figured out the basic stuff.
Okay, no, that sounds good. And then I have one last question, which we'll try to get to, is what is the best way for organization services to be included in a survivor's cancer survivorship care plan?
Say that again, please.
I'm sorry. What is the best way for our organization services to be included in a survivor's cancer survivorship care plan? And they're saying that they work for an organization that provides psychosocial support for people affected by cancer.
Oh, that's great. There's something at the end of the care plan that talks about resources, and what we've been doing is we put in some resources about our own institution, like where our patient and family resource room is, or the number to call, or the website to look for when we're having programs and classes. But because, for example, I see breast cancer patients, I've screened websites and programs, and I add the credible ones that I think are relevant to the population I see. For example, if I see a lot of young breast cancer survivors, I want to make sure that the Young Coalition for Survivors is in there. So what you might want to do is make sure that people are aware of your services and suggest that, or you provide a little blurb with your URL that they can just dump into a care plan. For example, in Epic, you're allowed to create smart phrases and then dump the smart phrases into the record. And so I have a bunch of smart phrases. One's on physical activity, one's on your survivorship care plan was just delivered and will be delivered to your primary care provider. So you can create things that might be useful to people who are using electronic health records.
Okay, that has been wonderful. Thank you so much, Dr. Meyer, for sharing your expertise, and to our participants for joining us for today's webinar. We had over 200 participants today, so it's definitely a topic of interest. We're going to go ahead and share some more information about our own CA SNAP resources, and then following this webinar, all the participants will receive an email with the recording and today's slides, and they will automatically be redirected to an evaluation survey to provide feedback on today's webinar at the conclusion. And again, you can follow us at GW Cancer Inst, and you can also check out our website. And again, thank you so much for joining us, Dr. Mayer. It has been a great experience. And again, we did upload those 2 ACP links that you suggested, and so they are available to participants at this time as well if they would like to download those.
That's super. And let me just also add, if people wanted to email me directly, my email is dmayer@unc.edu if you need further clarifications of things that we didn't discuss. And I know that many people that were in the audience are doing this themselves and may have other tips to share in what they've done or their own experiences.
Thank you. And we will definitely keep this in mind, again, as a hot topic. And thank you for sharing your contact information. We'll make sure to include that in the email. And again, thank you so much, Dr. Mayer.
Thank you.
Have a wonderful
Bye-bye.
day, everyone.
Thank
Bye-bye.
you.